And so, but now I'd like to introduce Erick Seelbach. And Erick, who I'm sure many of you know, has been active in HIV work for more than a decade, with experiences ranging from participating in an HIV vaccine trial to chairing research community advisory boards, from outreach to community planning to program design, and from nonprofit technical assistance to training to policy work. He is very interested in systems change and building collaborations across sectors and enjoys working with people across the entire Pacific Northwest to end the epidemic. And I'll mention also that Erick is my co-chair on the CFAR Community Action Board here in Seattle, and is also a member of the planning committee that put this symposium together. So here's Erick.
Okay, here we go. Thanks for your patience. So I get the excitement of presenting the epidemiology of HIV among MSM residing along the Interstate 5 corridor in Oregon and Washington from Bellingham to Portland. And this will be quick and brief. The data comes from Public Health Seattle King County, from Department of Health in Washington, and the Oregon Health Authority. They very graciously answered lots of emails from me about the data. So they basically put together the presentation, and I just get to give it, which is kind of fun, right? One of the reasons we wanted to do this is that so we're sort of all coming from the same place of information about the epidemic. I'm not sure if there'll be any big surprises. If there are in this, I would love to hear what surprises you. But we'll sort of go through it fairly quickly. So basically, this is looking at in Washington, the counties that border or that include I-5 going along that you can see on the right side of the screen. So where I-5 goes down, and then Multnomah County, which is in red in Oregon. So the whole presentation has Oregon on the left, Washington on the right, with as much similar data as we could compare. And so you'll remember that Oregon data is about Multnomah County, which includes Portland. Washington data is all of those counties that I-5 goes through. So in Oregon, then there's an average of 99 new infections a year. In Washington, it's about 331. If you look at the pie charts, then the blue represents white. On the Oregon chart, red represents black. On the Washington chart, orange represents black. Green is Hispanic on both of those, and then other is that funky deep blue purpley color. So these are percentages of numbers purely, not rates, numbers. And then if you look at the charts along the bottom, the age range, very similar in both places. So lower in 13 to 24, big jump up with 25 to 34, and then slower declines down to 45 plus. But a similar kind of spread. In terms of late diagnoses of HIV cases, in both places about 29%. Somewhat similar reports of when first CD4 results come in. 89% had first CD4 results within 90 days in Washington, 83% in Oregon. If you look at last negative HIV test result prior to date of HIV diagnosis, we have this data for Washington. I didn't get it for Oregon. I'm not sure if Oregon collects it in the same kind of way. Going back to Joanne's point about, and Patrick's point about intertest intervals. For MSM in Washington, the median testing interval was 300 days. You'll note then that on this pie chart, 40% of MSM didn't know we didn't have that data about their last test, didn't know when they had been tested. 9% had never been tested, which seems to me a fairly large percentage. 21% over 12 months ago. In terms of MSM living with HIV, in the two places, there's a fairly similar percentage increase over the years as we would expect. 3%, 3.3 in Oregon, 3.6 in Washington, so the numbers are increasing. About the same percentage diagnosed with AIDS in 2012. Fairly similar age ranges, 59% age 45 and older in Oregon, 60% age 45 and older in Washington, 13% 60 and older, 12% 60 and older. So fairly similar there. Care status, in Oregon, 72% having a CD4 viral load result in the last 12 months, 68% in Washington, so that represents folks who are in some kind of care. Here's where there's slightly different definitions of virologically suppressed. It was 80% in Oregon and 54% in Washington, and here's where I say I'm not an epidemiologist, and I could not understand the explanation that they gave me for that difference, so I don't ask me to explain it. Jason Carr is sitting right there, and if you ask him, he'll probably be able to tell you far better than I what that means. But anyway, there those are. The cascade of care is sort of the frame of the conversation these days, and this is Portland Metro's stages of engagement in HIV care. You'll note 80% HIV diagnosed down to 58% undetectable. So that's Portland Metro. Here's King County's 85% diagnosed down to 58% virologic suppression. In terms of some other STIs and other cofactors, this is syphilis cases. The top chart is Oregon. The bottom chart is Portland. You'll note that a significant portion of those syphilis reports were in folks who were HIV positive. Those are the green bars next to the purple ones. This is from Washington State. Total cases of gonorrhea and syphilis among MSM. For gonorrhea, 16% previously HIV positive, syphilis 45%. So again, significant numbers. Skip through that. Seattle participates in the National HIV Behavioral Surveillance Survey, NHBS. Portland and Oregon do not. So this data is from Seattle alone, where HIV seroprevalence about 19% in those who participate in the survey. 81% of those who had tested positive at the time of that survey already knew their status. 100% of those who had self-reported being positive had seen an HIV care provider in the last 12 months. This one has all sorts of information about sex partners, differences among HIV positive and HIV negative. These slides will be available on a website. Yes, Joanna? On the web? The slides after. We'll send a link. Okay, just to remind you. So you'll be able to look at this more closely. Thanks. Oh, great. Medical Monitoring Project data has some more information about folks who are in care who are HIV positive. So from Oregon, the data, 62% of those in care identified as gay, 9% bisexual, 40% in poverty, 68 had some college education or higher. In Washington, the educational, 45% had some college, 15% bachelor's, 12% above. Income in Washington, 53% less than 133% of federal poverty level. If you, basically, like my impression of that, of all of this as a non-epidemiologist, is that the epidemic is remarkably similar along the whole corridor, from Bellingham to Portland. There are, of course, differences in the cultural environment of Oregon versus Washington, of Portland versus Seattle. Portland's kind of weirder than Seattle, according to the television shows. But we still have our weirdnesses here in Seattle. So we have to understand the sort of relative cultural dynamics at play. And then in between Portland and Seattle are these stretches of rural and suburban places. Also north of us in Snohomish and further up Bellingham, smaller places. So we really have to understand what's going on for MSM in those particular areas. But overall, fairly similar, fairly homogeneous kind of epidemic here. It's important to know that we don't know enough about the racial and ethnic disparities here. We know that the same disparities that exist in other parts of the country also exist here. We don't have a good estimate of the number of MSM who are living in that I-5 corridor. So it would be helpful if we counted all of us, so we could help figure out the rates and figure out more about the disparities, so that we could, have that information. Particularly as we look at things like the continuum of care, where we need to know more about who's falling out along each of those steps. We need to know more about HIV and hepatitis co-infections, about migration patterns. I mean, we all know that gay men and other MSM, we move around. We visit other cities. Every time I'm out in Portland, I meet Seattle people. When I'm here, I run into Portland people, and then everywhere in between. So we're moving back and forth, and the parts of the conversation that I hear are that people blame infections on the big cities. So it's Portland's fault, it's Seattle's fault. So people go there, play, get infected, and take it back to their other places. So that's part of the conversation to figure out, is that really happening in the way that it's talked about? How does the migration patterns, how does the movement of gay men throughout this corridor impact risk? Need to know more about housing, about employment status. We know a lot about stimulant use. We need to know more. And then more about the racial and ethnic disparities like I talked about. So that's like the really high level overview. There it is.